Okay.
Sir, good evening.
Good evening, good evening. Okay, we can start now. Asmita, shall I start?
Yes,
Asmita?
Yes, sir.
Okay.
Yes, sir.
Okay, thank you, thank you. Okay. So, good evening to all of you. This is the 168th session on this challenging case series. As usual, I will start with a short case first. Two short cases, in fact. Is screen visible?
yes.
Okay.
Yes.
Okay. So this is a story of a 24-year-old lady. She fell down from her bike 2 days back and sustained fracture of the left arm and admitted for surgery of the left arm. Immediately after the fall, she noticed pain in the neck and right arm. At that time, she was able to move her right upper limb. However, about 3 to 4 hours later, she noticed difficulty in elevating her right upper limb. About again 2 to 3 hours later, she noticed numbness over the lateral forearm and total inability to move her right arm. That's the story. So after the accident, about almost immediately, she noticed pain in the neck radiating to the arm, followed by 2 to 3 hours later by difficulty elevating the upper limb, and then 2 hours later by numbness over the lateral forearm and total inability to move her right arm. So this is the video of the patient.
Right examination.
It's got deltoid is weak. Biceps is also weak. You cannot keep markedly weak. Supinator was weak. Pronation was good. Pronation was good power. And a good power of pronation. Supination, however, was weak. Triceps was normal. Normal. Finger extensor is normal. Finger plus is normal. Extensor is normal. But external rotation is very weak. But internal rotation is very normal. You could internally rotate, but definitely. Biceps reflex is absent. Supinator was present. Triceps was also present. Check once again. So where to press just sensitive. Sensory system. She has got sensory dulling over that area. That aspect of the arm. Then also over the lateral forearm. That area she's telling is normal. That area is normal. There is now it's become normal. It's number on that side. He's become normal in the thumb. The thumb and index finger is normal. Medial forearm is normal. Posterior aspect also normal. But the lateral area is now. That is the area which there is able to feel. Is able to feel. So an examination, she was in a collar for neck pain. Grade 0 to 1 power of right deltoid, biceps, brachialis, supination, and external rotatus. Pronation was good power, about K to 4 plus power. Triceps and other wrist finger muscles were normal. DTR right biceps was absent. Supinated triceps plus was 1 plus. This is the area of sensory dulling over the patient, over the upper lower part of the arm and lateral part of the forearm. Sparing the thumb, sparing the index finger, sparing the medial forearm and dorsal aspect, posterior aspect of the forearm. So what is likely diagnosed? This has happened after the RTA.
What about rhomboids?
Rhomboids you cannot say because patient is bedridden because of the collar and he has got a fracture of the left upper limb. If she is having severe pain, she is posted for surgery next day.
Would be a 5-6 radiculopathy or upper trunk brachial plexopathy.
Okay. 5-6 radiculopathy versus upper trunk. Okay. Any other thoughts from anyone?
Brachial neuritis.
Okay. Affected the upper trunk. Okay. Right. Then. Okay. Let us see. So why not C5-C6 radiculopathy? That's the first question. What are the points against C5-C6 radiculopathy? See, I could not examine her serratus anterior rhomboidus muscle because she was bedridden. And NCS cannot help because it is only 2 days duration. So NCS is going to be normal anyway, even if it is axonopathy or a root plexus. So what are the points against root affection in this patient? Anyone can point out what are the points against?
So much
Pardon?
power loss usually doesn't occur early.
No, it can occur. That is not in root patient.
There is no.
If the root is dependent upon damage, both roots are affected, it can.
The pronation is not affected.
Oh yeah, that is the one point. Very good. Pronation also the same root value. Pronation is mainly C6, C7, but C6 is also dominating. So that is spared in this patient. Nothing else in this patient, which is striking in this patient.
No root pain.
No, root pain, that's not an issue. She has got a pain in the neck radiating to the arm. That can occur.
Supinated jerk is persisting.
Correct. That is another point. Very good. So these are small points by which you can say. One is sparing the pronatus. And the most important, the sensory loss spares the thumb. See, if you are so you must have seen any number of C6 radiculopathy or a C7 radiculopathy due to disc prolapse. Where do the numbness occur? Either in the thumb or the index finger. They never come to the lateral aspect of the forearm. Haven't you seen that? In root lesion, it is there are some, what do you call the specific areas where they get affected first. A C6 radiculopathy cannot produce lateral aspect of the numbness lateral forearm without involving the thumb. Here the thumb is totally spared, only in the distribution of the lateral aspect of the forearm, suggesting what? The distribution of muscle cutaneous nerve. The area of sensory loss corresponds to the axillary and maxillary. And also you see axillary nerve sparing in between and then producing the sensory loss. And these are the points favoring this thing. So that was another point is the sparing of the brachial is suppressed the supinator check, which relatively spared, which also supplied by the same route, C5C6 route. So the patient was advised steroid because no other investigation can be done at that point of time. So any questions in that case?
MRI not done, sir.
The MRI was not done. The patient was already taken for planning for surgery. She couldn't be mobilized at a fracture of the left arm.
Did she improve with the steroids, sir?
No, it's only I saw the patient only last 5 days back. So I'll be seeing this weekend. I'll be seeing that patient. But you can clinically very typical. See, one point remember is that following and surgery, following trauma, brachial neuritis is very common. Why it is occurring following trauma, why following operation and all, we do not know. Following cesarean section, etc. These are some triggering factors for brachial neuritis.
Ought to be immune mediated.
Yeah, but it's immune mediated, but why it is occurring following surgery or following trauma, we do not. I don't know, but this is very common. Literature also says this is precipitating factors is preceding trauma.
But it is fairly
Okay.
rapid onset.
Rapid onset. It actually, if you look very carefully, it is not the traumatic damage because your weakness progressed over a few hours' time, not immediately. But that cannot rule out a radiculopathy due to trauma, but that's usually, that again tell you it's a relatively subacute, not abrupt onset. Okay, shall we go to the next 2 cases? 2 more short cases, then go to the proper long case. This patient was brought with a history of weakness on the left side 2 days back. 2 ultra short cases. This is the lady. I am asking her, what is her problem? She does not respond. Repeated asking questions, she again does not respond. Ask her where is her house. Ask her name, no response. Then she's, after a long time, she mumbled a word. Again asked her what happened, what is her house, no reply. As I put out the tongue, this is how she put out the tongue. Ask her to lift up her left upper lip, it is weak. It falls down 0 power. The right upper limb is good power. She is not trying to do that. She is keeping it now. The upper limb. Left lower limb is also relatively good power. Left upper limb is 0. The reflexes are not going to help much in this patient. They are all normally irritated bilaterally. I must go to lift up her right upper lip. Now she has lifted up her right upper lip. Ask her what is the thing. She said what? She now obeyed the command. Usually I have to coax her very much. So on examination, she was apathetic, grossly inattentive. She left hemiplegia, grade 0 for the left upper limb, grade 3 plus for the left lower limb. So where is her localization? A symbol, no?
Right frontal.
Okay.
Okay, it's acute presentation.
Right MCA, sir.
Right MCA territory infarct. Good. Okay.
Right
Any
MCA
other?
territory infarct.
Okay, that's the thing one should easily consider. Now, right MCA stroke. Now, how to explain the severe apathy and indifference to the problem in the patient? She is not responding quickly. It takes long time to answer. Somebody does not at all. I ask you what is the problem. She did not tell anything. Pardon? Your voice is
Caudate.
Yeah, it can be due to the caudate mutism. Yeah.
Caudate
right.
nucleus.
Right. That's penetrating artery involvement of the caudate can produce apathy, correct? And it's very common in right MCA stroke, especially due to the involvement of the parietal and frontal cortex. Why the parietal cortex right side is affected more? I'll tell you the reason. This is called anisodiaphoria. This is a phenomenon seen with right hemispherical lesion. Anisodiaphoria is a condition in which person is indifferent to the existence of the repair. It is specifically used in association with indifference to paralysis. It is some kind of a somatosensory agnosia, a mild form of neglect syndrome. It's a disordered body schema in which the patient verbally acknowledged the clinical problem but failed to be concerned about it. Unlike our hemi-neglect, where the patient neglects hemiparesis, or anosognosia, where patient is deny or neglect the left side of the weakness. Anosognosia patient will not say they have got weakness on one side. But anosodiaphoria, they know they have got weakness, but totally unconcerned about that weakness. Anosodiaphoria follows a stage of anosognosia in which there may be verbal, explicit denial of the illness, and after several days to weeks, develop lack of emotional response. The indifference is different from denial, which is seen in anosognosia. Deficit. That's the difference. So what she's having some kind of anosodiaphoria due to right MCL stroke. There is a thing which one will consider. Okay. Now I'll show you another case. I'll tell you what happened to the patient later on. This is a story of a 45-year-old man was admitted with history of acute onset of inability to speak and weakness of the right side of the body. This patient had left side, and this patient right. I'm asking, calling your name, no response. He's not looking at my face.
ప్రాబ్లం వచ్చింది అది ఏమిటనేది వెతుకుదాం ట్యూమర్లో క్లాట్స్ అవేం కాదు లోపల రక్తనాళాలు ఏమైనా బ్లాక్ అవుతున్నాయి అనేది ఒకసారి చూడడం అది కనుక నార్మల్ గా ఉంటే బ్యాలెన్స్ ఆర్ వీక్నెస్ అంటాం పొజిషనల్ వర్టిగో అంటాం సో దానికి ఒకసారి ఎంఆర్ఐ చూసుకొని అది నార్మల్ అయితే పొజిషనల్ వర్టిగో ఏదైనా మొదలు పోతారు అందుకే ట్యూమర్ నాలుగు ఎందుకు ఏడ్చావు చెప్పు నాకు అసలు చిన్న సమస్య అది భయపడదు ఓకేనా స్కాన్ చేయించు నీ మనసులో పెట్టుకుంటుంది అమ్మా నీ ట్యూమర్ ప్రజలు అంటావా ఎంత పెద్ద సమస్య వచ్చినా అమ్మా నీకు ఏం కాలేదు ధైర్యంగా ఉందని చెప్పాలి అంటే నువ్వు ఎలా ఏడుపులు పెట్టావు అనుకో డాక్టర్ గారు ఏం చెప్పారు అనుకోండి ధైర్యంగా ఉంది చెప్తాను స్కాన్ అవని నన్ను ముందు చూడు
ఓకే I'm asking to lift up his, put out his tongue. Ask where is his house? As you look to the right side and left side. He's not obeying my command. Show his tongue and show the teeth. Put out your tongue. Open the mouth. Again. Put syrup over the right upper lip. Right lower limb is more powerful than the right, maybe 2 to 3 power. Right upper limb is 0 power. Global aphasia, right dense hemiplegia, mainly right upper limb. So where is localization in this patient?
Left frontal.
Due to, it's also stroke. Right frontal left frontal involvement due to what? Left MCA stroke. With what is causing his speech problem?
Kinetic mute, sir.
Pardon?
Mute is abuse. Mute.
No, I did not follow you.
Mute spelling. Ebulia.
Okay, abulia. So which artery is affected in this patient?
Nucleus accumbens by ACA.
Okay, nucleus accumbens by ACA, very good. So left AMC infarct producing aphasia right upper, that's one should consider. This case I had shown you back some time back. So coming back to my first case. So we all thought right AMC is stroke, no? This particular lady, this is the infarct in this patient. Right? It's got a right ACA territory infarct affecting the medial part of the prefrontal cortex, not involved in the leg area. So what is causing here apathy and mutism in this patient?
The medial frontal involvement.
Unilateral medial frontal involvement right side will not produce much of a problem.
Acute case.
Yeah, but some other nucleus is one which is more important for that. I'll come to that thing. Okay. Okay, this is some people say cingulate cortex dilation also produce. But you must see a number of AC infarct like this, which does not confined to the medial part of the cortex, does not produce secondary apathy. How to explain the right, that is upper limb weakness in this patient. It's left upper limb weakness in this patient with AC infarct.
The Hubner, facial-brachial.
Correct. So this is correct, artery Hubner, that's the thing. So coming back to the second case, this particular patient, this is the infarct. Same territory and the ACA territory, this is on the opposite side. So how to explain the apparent mute stage and how to explain the weakness of left upper limb? That's the question with this thing. Now, how to explain the facial-brachial monoplate AC infarct due to the effect on the Hubner's artery, as you were told? And what is the clue to suspect AC infarct? Patient was not having aphasia, but extreme abulia or mutism in the second case. So this is what is Hubner's artery. It usually arises as a single vessel, and as suggested by its name, courses backward along the A1 segment. This artery is typically the largest of the perforating medial lenticular striate arteries arising in the ACA. It can sometimes arise from the A1, A2, or at the junction of the ACA, ACOM, and ACOM junction of the ACA. Later, the artery characteristically turns posteriorly and runs in close relation to the gyrus rectus to reach the anterior perforating substance. Now, these are the vascular supply of the recurrent artery Hubner. Caudate, medial portion of the globus pallidus, anterior crest of the internal capsule, nucleus accumbens, diagonal band of Broca, and basal.
Now, can you be sure that?
Pardon? Joy, I could not hear you.
How can you be sure that the patient has no aphasia?
Because
How can we be sure that the patient has no aphasia? Maybe he has got aphasia also.
Okay, that you cannot say. In a person who is not speaking totally, you cannot diagnose aphasia. It's just like diagnosing an employee in the patient totally comatose patient without moving. So that's not possible. But look at that, in this particular patient, he is not aphasia because he's got totally mute stage. He's not speaking, trying to speak at all. Underlying aphasia, one cannot rule out.
Okay.
This is ACA infarction. Hemiparesis facial-brachial predominance has been attributed to infarction of the head of the caudate nucleus, putamen in the anterior portion of the internal capsule as a result of occlusion of the recurrent artery, Hubner's artery. Now, abulia in AC infarction. Persistent abulia can follow bilateral AC territory infarction. In unilateral lesions tend to produce abulia lasting for days. The specific structural damage causing abulia is uncertain. Cingulate carriers, supplementary motor area, and caudate have been implicated. Produce the face abulia. Okay. Any questions? I'll go to the proper case.
Sir, I think abulia responds well to fluoxetine. Have you felt so? Response of abulia to fluoxetine.
This patient had been under my treatment for seizure disorder on oxetol, 600 milligram BD for the last 2 years, and the seizures were under control. Presently admitted with a history of defective vision for the last 1 month. This defective vision becomes better by closing either eye. On closing the right or the left eye, her visual acuity was better than feels that on closing the left eye, her right vision is slightly better than when she closed the right eye. Putting in other words, even though her monocular vision is better than binocular vision, her individually looking, her left eye seems to be blurred compared to the right eye. Have you followed this thing? History, I will tell you once again. She complained blurring of vision, that is a problem. When she closed each eye, the blurring of vision is much better. But if you close individually one eye, she is not equal to, both eyes are not equal. When she closes her left eye and look to the right eye, it is better. When she closes her right eye and look to the left eye, it is better than seeing with both eyes, but less than what she saw with the right eye. You got the history? That is the thing she said. On asking about the presence of diplopia, she said she felt dizzy on viewing with both eyes and comfortable when she views with one eye. So what is the history diagnosis?
It has got a disconjugation of gaze along with visual impairment.
Or one eye, correct? Correct? Yeah. This, whenever the visual acuity is better when closing one eye, that means the underlying problem is likely to be diplopia, causing a blurring of vision. That's the thing which you consider, correct? That's perfectly right. In addition, in that case, visual acuity should have been equal on both sides. And one eye is better means she must have been having a decreased vision earlier also. That we do not know. See, she has developed diplopia now. Why one eye is better? We do not know whether she had got a decreased vision earlier. That will she hasn't noticed it before. Once it's closed for the first time in her life, she noticed left eye is slightly less compared to the right side, correct? That's also possible. Does not mean that this patient has got decreased vision, it just occurred now. Okay, am I right?
Yes.
Yeah. So that's both possibility, or it would have come along with the present problem, as Joy was telling, along with decreased visual acuity on one eye due to some problem, along with diplopia. Okay. So that is a history diagnosis, diplopia, with associated slight decrease in the vision, which might have been there earlier. But the odd point is that she complains of blurring of vision on viewing the left eye alone, apart from the fact that her blurring increased on viewing both eyes, the same point which we discussed. Let us look at the patient's video. Both pupils were dilated, left more dilated than the right. That is the right pupil, that is the left pupil is almost totally dilated. Ocular movements were all normal. In all angled I checked, there is no disconjugation of the eyeball movement. The blurring is also not particularly more to any one particular direction also. So check for the light reflex. No reaction to the light on both sides. Rest of the examination, upper limb motor system normal. Only other finding was his knee checks were well elicitable, but angle check I could not elicit.
ഞാൻ പറയുമ്പോൾ കൈ മുറുക്കി പിടിക്കണേ. ആ ശരി വിട്ടേ ഒന്നുകൂടെ മുറുക്കിക്കേ.
This were normal.
ഇതോ ഇതോ പിഴേ പിഴേ പിഴേ.
Rhombus negative and marking negative. So on examination, both pupils got dilated, left fully dilated, right mid dilated, did not react to light. Ocular movements normal. Rest of the scene exam normal except for the absent angle checks.
How was the fundus, sir?
Fundus normal. Fundus perfectly normal.
Was she using any drops, sir?
No, she's not using any drop at all.
Sir, home
She was,
sadness.
yeah, home sadness people is one possibility. Agreed?
Convergence.
To accommodation, sir, reflex to accommodation.
Okay, that I did not do at that point of time, correct? That should have been done. So,
Health tilting test, sir.
what was the idea of doing accommodation?
Whether pupil will constrict.
Yeah, of course, with what idea in mind? To go at a tactile pupil. Your reputation is correct. Tactile lesions. But tactile lesion by acutely occurring bilaterally, okay, there will be some other brainstem signs which is not there in this patient. But still, I should have done that thing in this patient to be complete.
Should be having a bilateral posterior optic neuropathy.
But here, visual acuity is perfectly normal.
Visual acuity കുറവാന്നല്ലേ പറഞ്ഞേ?
Allah, she's got a blurring only. The thing is, optic nerves are absolutely no optic atrophy in this patient. Visual acuity checking was okay, normal. It's literally good visual acuity. That I forgot to mention.
Maybe because of pupillary dilatation, she's having visual blurring.
Yeah, exactly. Yeah, that may be to the cycloplegia, she has got a blurring emission. Correct.
Hypohidrosis. Hypohidrosis, then it would complete that triad.
Hypohidrosis. In home side, why should put is hypohidrosis? That is an honor syndrome.
With areflexia and...
Yeah, that can go with home studies pupil. But the problem is that it's acute onset in 1 month duration. And it could be, is it angle present before also, we do not know. It can go with home study, I agree with you. But it's acute one. Acute home study, so-called home study effect.
Yeah, it could be a viral ciliary gang.
Yeah, correct. Neuritis, correct, perfect. The need not produce a loss of reflex also. Okay. So what we conclude is that it's got different pupillary deficit. That is correct, no? Everyone agrees with that point. Now, question now, how to explain the blurring of vision when the patient was viewing with both eyes, not when she was viewed with one eye?
Because of asymmetric dilatation of pupil.
Correct. Asymmetrical cycloplegia, similar to the history obtained by the patient diplopia. But she has no extraocular canine palsy. Now, how to explain blurring of vision when she viewed with left eye alone and not the right eye? There are two things you have to answer. One, blurring of vision can occur with different pupil deficit cycloplegia, as already told by Dr. Joy. She has, in fact, cycloplegia both eyes, maybe left more than the right, because left eye is totally blown out. Naturally, that ciliary muscle should have been paralyzed more. The refractive error caused by the cycloplegia is obviously more on the left eye. Right eye, it means partial, or if at all, is not there. So that is why she has got a blurring of the left eye more compared to the right side. It is not due to the loss of visual acuity, or due to the optic nerve involvement. Since the left eye was more affected by the cycloplegia, she has noticed blurring of vision, which is when she viewed with the left eye. Why then she had more blurring when she viewed with both eyes? This is something, so it's up. Have you seen persons coming to following cataract surgery, complaining of blurring of vision in one eye? Very, very common. Following cataract surgery, they come to blurring of vision when they view with both eyes.
That's because both eyes are having different powers of vision.
Exactly. Something similar to that is happening here. This is because of the acute onset of asymmetrical visual input from both eyes. The brain, which had been receiving equal input from both eyes, suddenly noticed a mismatch between the two eyes, causing problem in fusion of the images. To have fusion, the dissimilarity in the visual acuity can also produce fusion of the images. But this brain will do after some time. When you continue to have this problem for a long time, the blurring will disappear. The brain will adjust. But for acute setting, it will not. This is likely to improve as the brain gets accustomed to the disparity. Something similar to the blurring of vision one observes following cataract surgery of one eye. So they invariably go back to the ophthalmologist telling them my eyesight has worsened. Because one day he was only seeing with one eye, the other eye operated, blurring has increased. The ophthalmologist just wait for 1 or 2 months, you will become all right because of the brain to get accommodated, adjusted. So what is your diagnosis now? Efferent pupil deficit is that thing. We can explain why the binocular vision is worse compared to the binocular. Okay. So causes ophthalmic pupil or local pathology affecting the both third. So what investigation you need now?
So pilocarpine.
Pilocarpine test.
Okay. Have you tried getting pilocarpine drops? It's not available.
Like you have got no.
Yeah, I'll tell you the story. Tell you. It's very difficult to get. Okay, so ultimately I get it from this and the operation theater, but since it's not available with Idova search, I could not get. So I sent to my the local ophthalmologist whom I usually send. That's a different thing. So in the meantime, I sent the patient for MRI to find out any cause of pupil involvement. So because I was not getting pilocarpine to do the test. So this is the MRI of the patient. Look at the MRI. See, look at, she has got a loop, vascular loop, the pre-tectum, the tectum region comprises the dorsal midline. I'll show once again. This is the vascular loop. Abnormal dilated vein in the pineal cistern. This is a 3D flare. Again showing that dilated vascular anomaly. That's the area arrow pointing to the abdominal venous channels. Abnormal dilated vein. This is
That's more on the right side, no?
That's more on the right side. Again, you can. This is the sagittal cut, but it's present both sides. More on the right side. It's present both sides. That's an abnormal channel. This is also another cut showing the dilated vein. GRE. Compressing both sides of the tectum. This is the abnormal dilated vein in the pineal cistern. So MR venogram top is also done to find out whether it's arterialization of the vein. This is MRV showing the dilated vein. In the dilated vein there. And top shows that there is no arterialization. There is not picked up in top. Telling that it's unlikely to be a dual
Now, can they differentiate?
But because
there is no arterialization from the top?
Yeah, because if it's arterialization is there, then you will be picturing something like an artery. You can see the artery here, no? Did you see the artery on the other areas? See, this is the artery. So this will show the hyperintensity in the top images is its arterial flow. If it's a venous flow, that will not picked up in top. Unless the vein is have got a arterialization, that will pick up. Here the vein is not showing a bright signal.
Yes, sir.
If there is an arterialization is occurring, it should have shown a flow is faster, should have been showing a top picture should have become bright. Now, the question now is, can this abnormal vein compressing the dorsal midbrain be the culprit?
It's less likely because symptoms are more on the left side and
but
only for one.
That's true, but the problem is that location of the vein and the dysfunction may not correlate. This is in the region of the dorsal midbrain. Your point is valid. That you said, after all, it is affecting both sides.
Also, ischemia can also occur.
Yeah, many reasons. The thing is that there is a lesion there, and can it cause? It can cause.
Can cause.
But why should it present so acutely, sir? It is probably pre-existing, no?
We don't know. The patient has come with blurring. Most likely it has occurred simultaneously.
Convergence was correct, sir. Convergence.
Convergence is normal. I did not show you, but all ocular movements were normal.
This much of pupillary dilatation is unusual. It's more like a ciliary ganglion than detected.
That one cannot say. It all depends upon the degree of involvement. Okay, what will you do now?
Having bilateral is more favoring this. Maybe the bilateral presentation favors this to be the responsible lesion.
With the tactile region. Okay.
Yeah.
But tactile lesion also can be unilateral, also is possible. I'll tell you the reason, because after, I'll show the picture. After
No,
crossing.
sir, in this patient is bilateral involvement. No, so
Yeah, correct.
rather than affecting both ciliary.
Correct. What you said is correct. Right. But ciliary ganglion is
Sir,
also
if it is if it's a tactile lesion, will the upgaze will be affected?
No, that all depends upon which part of the tectum is affected. Theoretically, what you said is correct. The tactile involvement need not necessarily be due to the compression itself, maybe due to the ischemia itself.
Because the posterior commissure goes towards
right. Correct. Your point is valid, but the thing is that the lesion vessel is there, and that area can explain. So when there is a lesion there, all need not necessarily be there.
So we can do the pilocarpine test where you can do the pilocarpine test and see whether it is actually
correct. Okay, that is the thing. But what we are all clinicians. What clinical test will you do?
Light near dissociation, sir.
Correct. So can I compare? What will you do? So in fact, I already done an accommodation test, which I did not tell you earlier. Okay. So I did look for the accommodation. Convergence. Look at the pupil reconstruction. The second time that people write a pupil stick tell us now. The pupil did not constrict. Did not constrict with accommodation or convergence. I'll show the static film. No constriction. This is the convergence. No constriction pupil and convergence. So that means it's unlikely to be a tactile pupil. Now we are confident that it is not the lesion. Whatever is causing the compression of the vein is not responsible for the patient's present problem. Cyto lesion is not, then what's the cause? This already is a dilated pilocarpine test was done. So this is
can't tactile lesions cause the same finding? It has to be the accommodation. The pupil should constrict in tactile lesion, or it can also be.
No. It should constrict tactile lesion, because pathway for the accommodation is coming from the infront, not to the pretactile region. It comes directly from the parietal cortex to the third nerve nucleus, anterior to the aqueduct.
And
that is why differentiate between tactile lesion producing the pupillary dilatation versus the true efferent pupillary deficit.
So in Argyll-Robertson people,
correct.
tectum is the site, one side.
It can be one side, it can be both. I'll show you how it is producing. But the thing is that both will produce. If there is a tactile lesion, accommodation should be preserved.
Yes.
That's the point. That shows the light near dissociation. Home study can also produce that in late stages, and the explanation will come later. So this is a dilute pilocarpine test. See, this is before test. Right side it is 5.1 millimeter, left side is 7 millimeter, which I have underlined that thing. After 30 minutes after dilute pilocarpine test, right side has become 4.1, and left side has become 3.9. So after test, the pupil diameter decreased from 7 millimeter to 3.9. The right pupil decreased from 5.1 to 4.1. That means we know that here is a lesion. Where is the lesion now? Distal to the ciliary ganglion or distal to ciliary ganglion? That is a site of home-sided people. Okay. If it is proximal to the ciliary ganglion, the pupil will not constrict with this dilution. It will constrict with a larger dilution, sorry, with less dilution, with a larger concentration or greater concentration. So this still proves conclusively that the lesion is distal to the ganglion, and the commonest cause is home-sided pupil. So what other test will you do now? Because the angle check were absent, I thought the NCS also, that was normal. Then you not exclude or include the home-sided people. So what is the final diagnosis now?
Home-sided.
Home-sided people. Why it is so current? I'll come to later. So I'll show you another similar case, which
Why
is shown something.
Why is it so acute?
Yeah, I'll come to that. That point I'll explain to you later on, because I'm give a short description about the acute home-sided a little later on. I'll show you just another case. This case I have shown before. The story of a 24-year-old woman. 3 months back, one day she noticed burning vision on the left side, which remained like that without any improvement. She tried to close her either eye to find out whether the vision is same on both sides. She noticed that burning was present only on the left eye after reading, while reading. She also noticed that she had no problem looking at distant objects with the left eye, but only on reading book. So what is the problem there? That tells very clearly the problem of the blurring is due to the cyclopathy, the loss of accommodation. No other complaints. She's already gone to the ophthalmologist on examination. Pupils are dilated due to the mydriatic drop installation. So visual acuity is normal. Feels normal, Pandey normal. So what will you do now? The pupils are already dilated by the drugs. That's a problem when the patient comes to you after ophthalmologist. After seeing the ophthalmologist. The very important our examination finding, I mean, the sign is taken off.
Wait for a few days.
Correct. Same problem in same. So problem accommodation with the left eye. So she was sent back and asked to come after 3 days when the mydriatic effect was over. This is after 3 days. She came. Look, there's a right pupil is normally reacting, left is dilated, non-react. See that pupil. Okay, I think it's one part. So small, okay, so now the problem is now if you find that unilateral dilated pupil non-reacting light, it can be tactile pupil or unilateral ARP. It's home-sided. Home-sided is often unilateral. Is it a problem of early third nerve palsy due to some compression in the midbrain anterior to that, some aneurysm compressing it? Or is it a case of pharmacological blockade of the pupil, just like our patient had, the doctor patient had earlier, where the patient instilled eye drops in her eye to produce dilatation of the pupil. So these are the things you have to keep in mind when one patient comes to you with unilateral dilated pupil. Let us sort it out one by one. Now, this is the pathway for the accommodation. I'm sorry, the pupillary pathway. See, the pathway comes here. This is the pretactile nucleus here. The green one, it goes to both sides. It goes to the same side as well as to the contralateral third nerve nucleus. See, the lesion has occurred here after crossing, before reaching third nerve nucleus. It produces only unilateral dilated pupil. Okay. If it is occurring in this region, in the central region, it can produce bilateral dilated pupil, just like our if the ductal lesion is responsible, that can now produce bilateral. So this is a unilateral ARP. That's a pathogenesis of unilateral ARP. Okay. If it is lesion is proximal to the pretactile ganglion, you will not get a unilateral ARP. So what will you do now? find out the pupil consists convergence. That's the first thing, rule out tectal pupil. That patient I did the convergence.
Keep on looking it. Keep on looking at the finger. Keep on looking it. Keep on looking it. Keep on looking it. Okay.
So that exclude tectal pupil. So after the 4 possibilities, the tectal pupil is away, is taken away. Now, question is it home study? Is it a problem of early third nerve palsy due to some compression? Or is it a case of pharmacological blockade of the pupil? What will you do now? You have to do tests at various strength of pilocarpine. If dilute pilocarpine is done, if it is positive, it is home study. If it's other pupil, it will not produce any reaction. Third nerve or due to normal pupil, it will not produce any reaction. If it is negative, that does not react mean it can be either an early third nerve palsy or a pharmacological blockade. If it was a negative one, then what will you do to differentiate with third nerve palsy from pharmacological blockade? Use full strength pilocarpine. If it's the third nerve palsy is the one causing the pupillary dilatation proximal to the ciliary ganglion, the pupil will react only with the higher strength pilocarpine. But if it is pharmacological blockade, whatever strength the pilocarpine you use, it will not produce, right? Because peripherally it is blocked. So it will not act on that. That is to differentiate a pre-ganglionic third nerve palsy producing pupillary dilatation versus pharmacological blockade. The ciliary ganglion lesions, because of the denervation supersensitivity, the pupil will constrict with a dilute pilocarpine. So, the pilocarpine test with this help of ophthalmologists. This is the 15 minutes after dilute pilocarpine. You see that the pupil is constricted after pilocarpine. 1 hour dilution. This is 1 hour after dilute pilocarpine. You see, the pupil has become constricted to the normal size. So these are the parameters how differentiate tectal pupil versus the other one. Tectal pupil is dilated, light reflex is absent, accommodation is present. If it is a compression of the subarachnoid space, pupil is dilated, light reflex is absent, accommodation absent. Covenant is also same, both will be absent. The covenant lesion is produced mid position because it can associate a Horner syndrome also. That is, the pupil is not as dilated as a lesion proximal to that in the covenant subarachnoid space. If it is ciliary ganglion, the acute phase, in the case of people who may be dilated in tonic pupil, in chronic, it can become meiotic. I will explain later on. The points, what I have been told is the one slow constriction of long illumination. Pre-dilatation is very slow after illumination. So, Homesides pupil, this is going to answer your question, why it producing acutely and. See, initially, there is internal of the pupil become dilated with the loss of accommodation. Everything will be, that also will be lost. Late stages, large pupil reacts poorly to light, reacts slowly to near stimuli. Because the accommodation picks up earlier, become better than the light reflex. After instant refixation, the patient has to look from a closer view to a distant object. There is a tonic, slow tonic read. That is the hallmark of a tonic pupil. That is a transient reversal of anisophoria. I will explain why it is later. Let's show the picture. The tonic pupil is smaller because the normal pupil quickly redilates. You can have light net dissociation even in tonic in the case of Homesides pupil, because pupil constricts better to light than better with near stimuli than the light. Because the innervation ratio between the light reflex and the accommodation reflex. If you find the number of fibers destined for the accommodation that are more important than the pupillary constriction, the ratio is 30:1. For every 30 fibers responsible for accommodation, only 1 fiber is for pupillary action. That is, the accommodation, when it recovers, is become better than the light reflex. So you can have a light net dissociation even in Homesides pupil, but not in the acute phase, in the later on phase. The hallmark of the Adie's pupil is a strong and tonic response to the near stimulation with a slow and sustained relaxation due to iris sphincter aberrant regeneration and hypersensitivity to muscarinic receptor agonist pilocarpine. Over time, the tonic pupil, which is usually larger than the involved eye in the initial phase, tends to become smaller, a condition called little old Adie. The little old Adie's pupil can be diagnosed with poor light reaction and tonic near response. This is the Adie's pupil. See, this is abnormal pupil on the right side, which is dilated compared to the normal pupil on the left side. I written the abnormal pupil on the left side. This is on the bright light. In the dim light, what happened? The normal pupil dilates. So it becomes similar to that of the, both will dilate, but normal pupil becomes almost similar to that of the the affected eye, but affected will be a little more dilated than the other thing. Because there is normal reaction to the dim light, because sympathetic system is intact. To do the dilute pilocarpine test, what will happen? Our affected eye will constrict. The other eye will not constrict because dilute pilocarpine does not have any effect on the normal eye. So you get a reversal of anisocoria. Initially, the affected pupil was larger. With dilute pilocarpine, the affected pupil become constricted compared to the normal eye. That is what is called the reversal of anisocoria, which was referring to earlier. So what are the causes of tonic pupil? Idiopathic is the most common cause. The other causes include focal infectious inflammation like herpes zoster, syphilis, botulism, non-infectious inflammation like giant cell arteritis, systemic autoimmune neuropathy like GPS, Miller-Fisher syndrome and CADP, orbital vasculitis, giant cell arteritis and PA, all can cause ciliary. Other causes include malignant infiltration, paraneoplastic trauma, surgery, laser therapy. Now, this is what is called the benign Adie's pupil, which is the most common thing seen in healthy young women. Acute painless enlargement of the pupil and photophobia. Unilateral in 80%, associated decreased corneal sensation, postulated to be thought to viral ciliary ganglionitis. This is again described in the following COVID infection. So that's the story of this patient. So any questions on that case?
So why ankle jerk is absent?
Pardon?
In the first patient, why was the ankle jerk? It is usually associated with the home sadness.
It got long-standing home sadness. I do not know whether that's the beginning of a long-standing home sadness in this patient. May not necessarily be viral neuronitis.
But how do we...
Pardon?
Sorry. How to treat these patients?
Very good question. You know what I did? So here, what is the disturbing thing? Pupillary dilatation of this thing. So I put her on short course of steroid, but that is going to take time for the improvement to occur. But it is symptomatic. So what will you do? What I did was I put the pilocarpine drop in here. But unfortunately, in the market, what is available is only 2% pilocarpine. 1% is not available. So I was reluctantly, I put the patient, I put one drop on the eye and then came out. That evening, I had a call from that ward sister. Sir, your patient has become blind. But it's not blind, actually. The pupil has been constricted so much that everything appeared dark on her. Then I told her nothing to worry, it will become all right. Next day, she's become all right. So, I mean, you have to put a lower strength pilocarpine for the treatment. So what I asked the patient, you take 10 drops of saline, 1 drop of your pilocarpine, mix it up. After that, you put 1 drop in each eye. That is a center hope like that. Because that lower strength is not, you have to make the lower strength pilocarpine. That's the treatment which I had given the patient.
Sir, can MFS present like this way?
Yes.
Partial manifestation.
Yeah, I have seen Miller-Fisher presenting only with pupil involvement, only with ocular involvement with pupil is sparing, only with home studies like people I have seen. I think I'll show one case later. Only pupil.
Then how did you diagnose it as MFS, sir? From the antibody?
The antibody. Preceding fever, bilateral involvement, and then Anybody. And she had other features also. Then the only that she had areflexia, but ocular muscles were all totally normal. So what I meant was, among the ocular signs, it may be only pupil. That patient had areflexia also.
Sir, there was a dilated vein, sir. So on both sides, but more on the right side. The first case.
Yes, yeah.
So any patient was sent to neurosurgeon like that,
No,
sir?
nothing. No, nothing. It's only a normal variation. So that's called a dilated vein of Callan, venous anomaly. That particular vein is slightly dilated, that's all. That's not a very common. Our radiologist was telling it's a rare entity, not very common. Whatever it is not significant because if it's a dural AV fistula, it should be tackled. But there is no arterialization of the vein. That's why you took it off in this patient.
It's too unusual for the same patient to have such a venous anomaly.
Pardon?
Really unusual. The same patient having that venous anomaly, it's very unusual.
Correct. That's it. And that's why I bought the case. That is why each step is important for diagnosing pupil dilatation, accommodation, light nerve dissociation, and the pilocarpine dilute. All this important localize where exactly is the lesion. Otherwise, if you just see a venous anomaly and the tactile region, you will not jump into the conclusion of a tactile lesion. Okay, any other questions? Shall I go to the next case?
Yes.
But could it be a case of development balance anomaly?
That may be a development anomaly. That venous anomaly is a development. Nothing to do with our patient. It is only dated only because I did the MRI earlier than our.
There is a history of seizure in that case. Oxytol, she was getting oxytol.
Yeah, correct.
For seizure. So,
yeah.
Is there any other cavernoma in any part of the brain is also to be looked for?
Due to for a homicide people?
No, this is a separate entity. That patient was having the seizure and also getting the.
Okay, that's nothing to do with the. I think the whatever seen the MRI is not late causative for the seizure disorder. That's a entirely different site of lesion, and what she had was complex partial seizure.
Okay, sir.
Right. No, this is this case is Samia's case. He last time also showed one case. This case he wanted me to present. This 20-year-old male presented with headache on trying to read with occasional blurring of vision. This is only the history which is given to me. And symptoms are better when he closes one eye and fixates with the other. So this is the video. The patient is asked to look at the camera. Then he is asked to fix at the camera with the left eye and then with the right eye. Look at this.
ক্যামেরার দিকে তাকাও এবার বাঁ চোখ দিয়ে ক্যামেরার দিকে তাকাও বাঁ চোখ দিয়ে এবার ডান চোখ দিয়ে ক্যামেরার দিকে তাকাও আবার বাঁ চোখ দিয়ে তাকাও আবার ডান চোখ দিয়ে তাকাও
Looking to the right and left or something else?
And just 1 minute. I didn't hear it. Can you tell me Adie once again?
Is he asked to look to the right and left, or is he asked?
No. He's asked to the camera. He said, "You look with the." This is what Sami has told me. He's asked to look at the camera with the left eye. Then he'll look with the camera with the left eye. Ask you to look at the camera with the right eye. He will look with the right eye. Then the other eye deviates. Subsequent
bilateral exotropia.
Okay, exotropia, right. So I'll show the subsequent video, then I'll come to the. So it looks as if his right eye is fixing and left eye is deviating. This is the same picture I have shown you. And now it looks as if his left eye is fixing and the right eye is deviating when he fixes the left eye. Okay. When he fixes the right eye, left eye goes into abduction. When he fixes the left eye, right eye goes into abduction. So it's exotropia. That's correct. See the next video now. Testing the ocular muscles.
এদিকে তাকাও, ওপরে তাকাও, মাথাটা নাড়িও না প্লিজ, শুধু চোখ দিয়ে তাকাও, নিচে তাকাও, এদিকে তাকাও, ওপরে তাকাও, নিচে তাকাও, আবার ওপরে তাকাও, এদিকে তাকাও, এখানে তাকিয়ে থাকো, ওপরে তাকাও, নিচে তাকাও।
So looking to the right side, it looks as if it's got left middle rectus weakness. But looking to the left, it looks as if it's got a right middle rectus weakness. Correct? So what test you would like to do now?
Adductions.
Adduction test.
Okay, adduction. Okay, adduction test. Adduction test was done.
ফিক্স করো। এবার ডান দিকে তাকাও, বাঁ দিকে তাকাও, ওপরে তাকাও, নিচে তাকাও, আবার ডান দিকে তাকাও, বাঁ দিকে তাকাও, ওপরে তাকাও, নিচে তাকাও। ঠিক আছে, আচ্ছা এটা দিয়ে ফিক্স করো। ডান দিকে তাকাও, ডান দিকে, হ্যাঁ ডান দিকে তাকাও, বাঁ দিকে তাকাও, ওপরে তাকাও, নিচে তাকাও, আবার ডান দিকে তাকাও, বাঁ দিকে তাকাও, ওপরে তাকাও, নিচে তাকাও।
Okay, that proves what? Adduction is normal means it's not a palliative squint, it's a concomitant squint. Okay, that's part is certain. Now the question is, which is the dominant eye, which is the lazy eye?
They're alternating.
Normally, if the squint is occurring in one eye in concomitant, one eye will be dominant. So when he views with both eyes, the dominant eye will view this thing. When he closes the dominant eye, the lazy eye will take up.
It's
Here
alternating, sir.
Fixator, okay. Okay, very good. Let us see. Now, there is no dominance of any particular eye. It's an alternate fixator. Now, just before that, in fact, Samya wanted to explain how this is occurring. So, when I created some animation to how to explain the heterotropia, how we can the deviation is occurring. Now, there are two tests we do: cover uncover and alternate cover test. Cover uncover test is for heterotropia or manifest squint or established squint. Alternate cover test for heterophoria or a latent squint, where the squint is not obvious on straight binocular vision. Because binocular vision masks the latent squint because of the fusional Bergen's system. So this cover and uncover test is for to find which is the dominant eye, which is the lazy eye. So uncover test for heterotropia and alternate cover test for phoria. In cover and uncover test, how do you do? Why do you want to do? Can already say this patient's eye is deviated to the right side. That is a deviated abnormal eye. But how do you know he's mixing with the eye on which you think is fixing? He may be fixing with the other eye. The eye which looks straight may be anybody be looking at that, he may be looking at the other point. The confusion will occur, especially if the deviation is mild. So there the problem is you need a cover and uncover test. It is easy, it's gross deviation, it will be easy, but not in all other cases, it may not be that easy. How do you do cover uncover test? The patient is asked to fixate at a distant target, for example, a pencil head in the hand. A cover is placed in front of one eye and removed, covered and removed. And then the cover is placed in front of the other eye and then removed. It is not alternating. Cover, removed. Cover, removed. And what you look is the movement of the uncovered eye. Suppose it's cover, you look at what is happened to that, which is not covered. You cover, you look at what is happened in the other eye. That is how you do cover and uncover test. And one observes the deviation of the uncovered eye. Let us see, for example, let us see, this is the left eye is on the left side, okay? Not the one which you all shown earlier. I marked left eye and right eye. Now see what is happening. This is the normal position of the patient. Right eye is fixing, left eye is deviated inside. So he has got actually a heterotropia in the form of an esotropia. Left eye is gone inside. Now we do not know sometimes the right eye is the dominant one and the left eye is the dominant one. The right eye was fixing earlier, and the left eye was a squinting eye. When you put a cover in front of the left eye, nothing happens because right eye is fixing, nothing will happen. So let us put a cover in front of the left eye, nothing will happen. Okay, that means your right eye is fixing. Now, if you put the cover to the right eye, what will happen now? Right eye is not fixating on the object. So it does necessarily the left eye has to take up the fixation. It moves and takes up the fixation. Left eye moves to take up the fixation. But that tells you that that eye is the one which is deviating. That's a eye which is a lazy eye. Now, if you remove the cover on the right eye, this is what normally happens. Remove the cover on the right eye. The left eye moves to the original lazy position. That is the original position. So it goes to the original position. So only when you cover the normal eye, you see the movement of the lazy eye. Now you know which is the dominant eye. But removing again the right eye will dominate or goes and fixing the thing. Now, another scenario is that sometimes another situation develops. The same patient, if you put the cover on the left eye or on the right eye, when you remove the cover on the right eye, the left eye should have gone to its lazy position, the original position like this one, the other one. But it continues to fixate even the cover is removed from the right eye. Once the left eye becomes dominant, it is allowed to fix, it becomes the dominant. The other eye is neglected now. So it becomes, initially left eye was lazy, now the right eye has become lazy. Sometimes left eye will not go into its lazy position and becomes the dominant eye. Left eye continues to fixate, even the cover is removed from the right eye, it has now become the dominant eye. The right eye gets deviated, gone into lazy position. So this situation is called the alternate fixate. Okay? Is it clear to you know how this is occurring? If it's a dominant eye is the only one, then it should have been, when you open the other one, uncover the other one, the original lazy position should have manifested. But here, the original lazy has now become the dominant eye. That's what is called the alternate fixation. This can occur with either heterotropia or heterophoria, whatever it is. Any questions? Any doubts can please ask. Pardon? Can you tell once more? Yeah, sure. I'll go to the basic principle of cover uncover test is, asked to look at a distant object, you cover one eye and remove the cover, then look at the other eye, remove the cover. When you cover the eye, what you look is what is happening to the other eye, uncovered. When you cover the left eye, look what happened to the other eye, right eye. Left eye cover, look at the right eye. Now here what is happening on the left side, this is the original situation of the patient. Left eye is deviated. That is tropia. It has gone inside. Right eye is fixed. Right eye is straight. This is the original position. Here we do not know if it is, now it is obvious you can say right eye is fixed in looking at center. But so if it is mild, you do not know. The right eye was a fixing earlier, as shown here. Left eye was a squinting eye. When you put a cover in front of the left eye, nothing will happen because the right eye is already fixing it. Nothing will happen. So what do you look at the uncovered eye? Nothing will happen to the uncovered eye because your cover is in the lazy eye. Right eye is fixing nothing. So as told before, what you're looking is the movement of the uncovered eye. Nothing happens to the uncovered eye, right? Remains in the target. Now, if you now put the cover on the right eye, that is the normal or a dominant eye, what will happen? Your patient is the left eye is deviated already because it has become, so it has come back and fixate now on the target. It is supposed to take up the target. Okay. And what will happen to the right eye? The right eye, which is the dominant, deviates inside because the movement is conjugate. And here, the primary deviation, the deviation can give a clue regarding the paralytic or non-paralytic. The deviation inside will be same as before if it is concomitant. It will be more in the case of paralytic, because if it is a paralytic skin, the right eye has to move excessively to take up the target. And you forget about that. So the right eye deviates. You put a cover, the left eye has to take up fixation, and right eye deviates passively because of the conjugate movement. Dominant eye, which is covered, you take out that thing. The dominant eye fixate to the object just like before, the original position. Left eye has gone on to lazy. So only when you put a cover on the normal eye or the dominant eye, not normal eye, dominant eye, the eye will deviate. Okay. So when you remove the cover, again eye goes back to the original lazy position. That is a esotropy is now manifest. So that is the usual situation. When it's not an alternate fixator, a unilateral fixator with the dominant eye. That is usual situation. Okay, this much is clear to you. Now, this may not be the case all the time. So in the same position, patient I told you, you put a cover on the normal dominant eye on the right, so-called dominant eye on the right side. When you remove the cover on the right side, the left eye should have gone to its lazy position, like the one which is shown earlier. This is the normal initial situation. That is seen on the left side of your picture. But even after removing the cover on the right eye, left eye should have gone to the lay position, which does not go back to lazy position. It continues to fixate. Okay? The right eye.
What is the reason for that?
I'll come to that. It's continued to fixate and the right eye has deviated. So here the right eye is the dominant. The dominance has now shifted from the right eye to the left side. That is what is called the alternate fixator. Now, why should it occur is because it's usually it's one of the common things which occur. This is to prevent the blindness to occur, the amblyopia, exanopia. Suppose the eye is constantly deviated on one side, that eye will become blind. If you got alternate fixator, both eye got a chance to view the image and prevent from blindness developing. So that is very common. Imagine the patient for the Samia's case. Suppose he is fixing all along with the right eye. Left eye is not fixing at all. The left eye will go into develop into blindness. If it's alternately fixating, that eye will not become blind. This is called from the left eye will not go into. This is the same thing which is true. So it's called alternate fixating.
Why did this patient come to the doctor?
No, he came to the doctor that complained. I will tell you. I'll tell you. That's a complaint. Headache on trying to read with occasional blurring of vision.
No, he has this for a long time period. No, so why is he having headache now?
No, that I do not know. That's the story. He said he may be complaining of occasional blurring because it may not be there all the time. Sometimes the conjugation will try to cover it. I mean, the eyes may move simultaneously, or the disconjugation may be much more. That can produce some kind of a blurring of vision. You understood what I said. See, he's got each eye become alternate dominance. Okay. Sometimes when you shift it on one side, the other eye may not move properly, can produce some disconjugation and then become blind. Shifting from the alternate dominance to one eye to the other. Okay, any questions? Okay, shall we close today?
Okay, sir. Thank you.
Okay, thank
sir.
you. Thank you, sir. Good night.
Thank you.
One thing, sir. What was the treatment given for this patient, sir?
In this patient, if he has got in fact, if you want a binocular vision, the patient should undergo surgery. The deviation is mild. Suppose he's got a skin, the deviation is measured in terms of diopters, prism diopters. The prism diopter is less than 3, 4. That exact figure I do not know. You can give a prism glass to correct the deviation. So prism glass means suppose he's got a left eye is dominant, right eye is deviated. The prism glass will put in such a way that the eye will deviate because the rays will deflect because of the prism, and the eye will deviate and become sorry, eye will not deviate. The light rays will deviate and fall onto the macula. So you can have a binocular vision, depth perception. You got the point. See the light, what is happening because squinting eye, the light rays are not falling, one is falling on the macula, other is not falling on the macula, somewhere else. See, if you deflect that light ray so as to put onto the macula, then you can have binocular vision. Fusion will occur. So to make the deflection of the light ray, you can put a prism. What we call base out prism and basin prism. Basin prism means the cone of the prism is medially, the other cone is outward. Depending on the direction of the apex of the prism, the light ray reflects this way, medially and laterally. But this is possible only if the deviation or the squint is of a lesser degree. Because the larger degree of squint, as in this particular case, so much that this deviation is great, so great. There are so much that you cannot correct by prism glass. That patient should undergo squint surgery to make it parallel, laterally parallel. Mild disparity, the brain will adjust. Yeah, please.
Okay, sir. Thank you, sir.
Okay. Have you understood what I said?
Yes, sir. Yes, sir. I understand.
I will next week. I will show you what is a prism glass is like. I will show you.
Yeah. Okay, sir. Thank you. Sir. Good night, sir. Thank you so much.
Thank you. Any other questions? Sir,
the change in dominance is at the cortical level or just at the muscular level?
At the cortical level. It is because of the cortical level, it is a dominance is occurring.
Thank you.
Okay.
Thank you.
Okay, good night.
Good night. Good night.
Good night. Good night. Good night.
Good night, sir.
Good night. See you next week.
Thank you, sir. Good night, sir.
Thank you. Good night. Thank you next week.